I'll start with palliative care. I always kind of describe where we fit on the spectrum of advanced illness, and the supportive care is present at all stages of health and wellness. And when people are facing the final phase of their lives or life-limiting illnesses where the burden of suffering is great, in usually more than one way, then palliative care becomes what is best supportive care. And palliative care exists while we're still treating disease and while people's goals are about living as long as possible and controlling disease, but the focus is about quality of life and living as well as people can, as best they can, and to meet the goals they can achieve. And there's a transition to end-of-life care, and part of palliative care is making sure people have plans for the end of their lives to reduce the stress and burden and suffering that can happen without having discussions or figuring out how to integrate this person's worldview into this medical system. So hospice care, as you've just been speaking about, all of hospice care is palliative care, not all palliative care is hospice care. And I think one of the things I've come to really appreciate when we talk about how people want to die, and a lot of people say they want to have a natural death when I talk about what's important to you when you're at the end of your life, that what a natural death means is very different to different people, and it's also very much changed by how we address our health in general, and the technologies and advancements that we have in medical care have greatly changed how people die. And you didn't need palliative care doctors probably 30, 40 years ago by and large. But we are extending life dramatically by illnesses that people used to die much earlier from. And people will put up with a lot of burden to have a longer life, and we try to reduce that burden. But most people's goals are largely about controlling disease and extending their lives for as long as possible. And the burden of suffering can be tolerated. And then there's a point when people are done and we allow death. And so those are the goals that are frequently present as people face the end of their lives. Quality of life, longevity, and then that shifts to allowing death, and we stop preventing death. And that shift usually happens because death is coming, and symptom burden, psychological, emotional, spiritual, physical, all the studies show those dramatically start increasing in the last days to weeks of life for most illnesses. And so a lot about allowing death is actually because death is coming, and that's been my experience. So we look at palliative sedation as, a lot of people describe it as the last resort option for alleviating suffering at the end of life. One of the consequences of extending life and focusing on comfort while people are trying to live as well as they can with a life-limiting illness is that we use pain medicines and other medicines to assure comfort in that time and help maintain function. And there are things that can happen at the end of life as a consequence, either from disease becoming so advanced or so disruptive to the body, or because those medicines, the body becomes tolerant to them and they don't work as well, that when we go up at the end of life, people might be more prone to delirium. But there is a real problem, and it is related to how we have, for good reasons, extended life, but things can get very challenging at the very end of life. And that's where we have our traditional means of alleviating suffering, and if those don't work, then we do what's most commonly described as palliative sedation, where we are sedating somebody with the intent of alleviating suffering because no other means are able to work. It is very, very rare, and I can think of maybe one case in my career of somebody who was wishing for or needing palliative sedation who wasn't otherwise in their last days of life. And I just want to kind of highlight that piece. And we talk about how most people die and what's important to them, that these decisions about focusing on comfort and allowing death are most common because death is near. The use of sedation in medical practice and in palliative care, there are 3 levels. I'd like to separate this out for learners when we're, to help also highlight when palliative sedation, how it is different from what we more traditionally do in medical care. And so ordinary sedation is you receive a medicine for pain, it makes you groggy, it's not a wanted side effect, it's not a necessary side effect, and we reduce the dose. We might use a sedating medicine at night to help somebody sleep, like a sleeping pill. So that's ordinary sedation. It would not be desired during the day. We would dose reduce if someone was sedated, but if at night someone had pain or they had trouble sleeping, we would accept sedation as actually the helpful to allow them to sleep. So we use sedatives all the time in medical care. Proportionate palliative sedation is when the intent of the medicine is to treat a symptom, most commonly pain or anxiety or restlessness or shortness of breath. And the medicines we use to treat that symptom are opiates, which is morphine class medicines, and benzodiazepines like Ativan or Valium. And those medicines, dose dependent, can cause grogginess. So we work to find the least sedating dose, because usually goals are about maintaining quality of life, comfort, and being able to communicate. And we work to use the lowest dose possible to achieve comfort. And most people can be comfortable with that degree of symptoms, except at the end of life. But most people can be comfortable and not be sedated or groggy. And if their goals, if I were to give morphine for pain and somebody were to feel groggy, I'd say, is that acceptable to you? Is your pain, would you rather have less, would you rather we reduce the dose so that you could be more clear? Or are you at a place where you'd rather accept the grogginess because you want to be comfortable? And so that's where goals of care really matter. And I work with where people are at in their stage of illness, and sometimes tolerating grogginess for a few days, and then someone gets used to that medicine and they're no longer groggy. People can become tolerant to very high doses of these pain medicines and live with them and not be altered, and reduce some very difficult symptom burden that you can have with advanced disease. So that's proportionate sedation. And then palliative sedation, well, I'll add the other part of proportionate sedation is people that get sedated on pain medicines. So when you're uncomfortable and we give a pain medicine, usually we can get somebody comfortable without causing grogginess. And we have more than just morphine. And there's a point where sometimes the side effects of morphine, but somebody is still uncomfortable. And that happens more commonly with advanced disease and more commonly at the end of life. And that has to do with the body's reserve. And people are groggy or tired already, that this can augment that. And then in this work, I've really learned to realize where are people in their stage of life and stages of dying, and how can we best find this balance, but also being able to recognize when is somebody getting groggy on the morphine because they were otherwise dying. And there's usually a trajectory leading up to that to know that, because sometimes there is a point where you can't be awake and comfortable. And the trajectory of dying is that you become less and less conscious over a period of hours. And what triggers dying is an interesting phenomenon that I'm still trying to figure out. But what dying looks like is over the last hours to days, somebody becomes less and less conscious, in and out of awareness or able to communicate, and there might be changes in how they feel, extremities feeling warm or cold. And then there are breathing changes that are universal, where people have pauses and breathe fast and pauses. And it's really remarkable when people are able to communicate at a time when they're having those breathing changes, because their consciousness alters with those breathing changes. It's something that we don't understand. I think we understand childbirth a lot more than we understand what happens when you leave this world. But there's something that happens, and it's autopilot. And people might look like they're in their last minutes and go into this stage of dying that then takes hours to days. And that dying looks the same whether it's cancer or lung disease or heart disease. And that just gets triggered. And so there is a piece about what triggers that in this work. That is it letting go, that we push so much that we're ready? Or is it that the body is changing, the symptoms are getting worse, and then something just triggers this? But we really do have, I've learned to believe, sometimes it's triggered by medicines meant to get somebody better, and it pushes them out of balance in a certain way, and they're so close to the end of their lives that dying starts. So I don't feel like in my work, and for the medicines even that I use, that we have much control over how much time somebody has. Most days I feel that way. And time could be short, even if someone's picking the path they think that will give them the longest life. And what we have control over when you're that close to the end of your life is what happens day to day. But when you die, we start to lose control over that, and naming that, because I think people worry that choosing these medicines or giving up to be comfortable, but we could hasten death by doing chemotherapy, and frequently oncologists talk about that too. So when you're that close to the end of life, it doesn't matter what you do, death is going to be triggered, and what we have control over is how comfortable you are. And that goal of comfort and consciousness, that's a very individual choice. And people will say, I'd rather tolerate this level of pain because my daughter is flying in from California and I want to be sure I'm as awake as possible to see her. And I've had other patients say, I've been suffering with, I've pushed against this pain for so long that I am done and I'd rather be asleep. And then that allows, if you're still uncomfortable, and you would tolerate sedation as a side effect, that we can go up on the medicine and allow sleep or allow sedation. The intent of this and that proportionate sedation is still that we're trying to find a balance, and that there might be, it's permission, that going up on this medicine, if you're already groggy on morphine but you're still in pain, that for me to go up on that, the grogginess will get worse or someone will become more sedated. But it also allows, I don't know what's going to happen when you wake up. Some people, their pain is severe, and using sedatives, which help anxiety, which can be part of pain too, that some people just sleep and they wake up and they have this reprieve of just this more comfortable place where they can be more alert. But close to the end of life, when we go up on that medicine, I don't know that that's what's happening, because death may be triggered, and I just like people to be prepared and to have that choice. And so that's what dying looks like, and that's proportionate sedation. That is universally just part of end-of-life care. And sedatives are a very important tool as people face difficult symptoms at the end of their lives. Palliative sedation, the intent is different. So the proportionate sedation is to use medicines for pain and anxiety and accept sedation as a side effect. But palliative sedation is, the intent of the medicine is sedation. And it's when all other treatments have been tried to alleviate whatever the distress is. And it's different than proportionate sedation because it doesn't allow that somebody is going to wake up and eat and drink. That once you make the choice to do palliative sedation, you're at a place where there's no comfort aside from reducing level of consciousness. And most of the time, the intent is to maintain sedation until the end of life. So in almost all cases in my career, that choice has been part of being at the end of life. And it's, the intent is not, we're not using, we maintain pain medicines, but if it's refractory severe pain, we're using very sedating medicines for the intent of sedation. The most common medicine I use is phenobarbital, and other people use benzodiazepines like Ativan and Versed. And we use phenobarbital in infusions to treat seizures, and it's called a phenobarb coma. And that's done in an intensive care unit with somebody on a ventilator. And this is where that picture of end of life, like we could sedate somebody and prevent death by putting them in an intensive care unit, put them on phenobarbital like we would use for seizures, but we're using it for refractory pain, and put them on a ventilator. And you could even support them with fluids. And then they would die. How? How would they die? And what's natural anyway? Being on a sedative, my experience is most people die because they're already dying. The experience when people have studied this is that most people, for true comatose, like to the level of being minimally or unresponsive, that most people die within 72 hours of initiation of a palliative sedation protocol. And because when the goals of care at that point are because somebody is dying or relief of suffering, allowing death, and because things were usually very tough until then, and we don't expect someone to be awake and comfortable, that extending life at that point is not a goal. That allowing death and making sure we don't do things that are going to extend this final hours to days of somebody's life, and that includes fluids or nutrition. And in a sedated state, somebody is not going to eat and drink. And that's what's different about this than proportionate sedation, is the outcome, no matter what was happening with the disease in the body, but death is certain once we decide to palliatively sedate somebody. And that makes it feel a lot different than anything else we really do in medicine. And so we take a lot of time with the team and the nurses, and before we even talk about this with family, to just make sure that we feel like we've done everything we can and that people are comfortable with this, and that if people haven't had a chance to be part of this and really want to wrap their mind around this, I give them permission to not be involved. It's been supported by the Supreme Court, and maybe this has been covered already, but the Supreme Court has supported that palliative sedation, the intent to alleviate symptoms even if an outcome is death, is acceptable. And I think so. I feel like he's asking a question. Does everyone say that?
Everybody says that, yes. We
I
have
think we're
to
going to stick him
put a
outside.
coat, or hang a
Yes.
coat on his arm or something.
So that's what leads us to palliative sedation. Most commonly it is at the end of life. It's most comfortable when it is at the end of life because death is already happening, and it's when we've tried everything else. And it is very much at a time when people are not looking for either the patients themselves or family members to extend life, but to allow death and not prevent death. And clinically, and my experience has been that most people die from, if they're not dying from the cancer or the underlying illness, that being in a sedated state without a protected airway and being in bed is a risk for pneumonia. And I've had 2 situations of somebody where they were facing very severe symptoms and was using sedatives to be comfortable, and one person was had a very agitated state at the end of their lives, and we were using as needed proportionate sedation. And how that played out over days was that he was in and out of consciousness, but he would wake up and be in a very uncomfortable and agitated state. And then we would sedate him again with medicines, and eventually he died of a pneumonia, and it was over a period of days. And then I had somebody else where it was similar at the end of life with end-stage disease with very refractory symptoms that once we recognized he can't wake up and be comfortable, that we titrated the meds to sedation and had family consent for that, and he died of a pneumonia. And there's a lot of different roads to go that way, but pneumonia is a common path. And that's what we've had 2 patients who have had palliative sedation protocols at the end of life and had autopsies done for various reasons, and both had pneumonia and both clinically appeared to be catching pneumonia. And that's where we're doing whatever it takes to be comfortable, and we allow that life is going to end in some way, and our goals are just to make sure that people are peaceful. Where palliative sedation gets less comfortable is when people aren't otherwise at the end of their lives, and it feels more like this treatment is in fact hastening death, which is not how I feel for the overwhelming majority of what I do. It's that reason why I think physician aid in dying is also uncomfortable, as the outcome is death, and the medicine is a clear agent of causing death. With physician aid in dying, the intent of the medicine is to induce death, and the agent of how that's administered is a patient taking it themselves. In palliative sedation, for people who are facing the final phase of their life but are not otherwise in their last hours to days, the medicine is titrated, and the intent is to alleviate suffering. The intent is not to allow death. And then we make separate decisions about we're not going to prolong life, and by doing artificial fluids or putting somebody on a ventilator. And so in that way, the medicine's intent is to alleviate suffering, and it's the other decisions that we're making which are well-founded and people are comfortable with. We're not doing artificial hydration, and we're not going to artificially feed this person. And it's more uncomfortable when somebody's not at the end of their life, because it's a little bit of this, it feels a little bit like a nudge, nudge, wink, wink of, is somebody making this decision because they're ready to die and they actually want the outcome of death. The experience in Oregon and Washington and talking to colleagues there, a lot of palliative care providers want to distance themselves from this issue. They feel like it's a sideshow and it distracts from what matters to the overwhelming majority of people and the things that they face. And it also undermines the work we're trying to do in palliative care, which is that we are not, people can live and they do not have to accept that we will hasten their death to titrate medicines and things like that. People can be comfortable and still want to live, and we can titrate medicines to achieve those goals. The experience in Oregon and Washington has been that people who choose physician-assisted suicide are, it's for more existential reasons of loss of autonomy, or the burden of living in a debilitated state that's worsening towards the end of life, and identity. And when I think about what a good death is, I tend to care for a lot of people at the end of life, and I talked about this process that happens that seems to have autopilot, that has probably more going on than we will ever know. And I picture that when I picture a good death, and that in palliative care you have to recognize a lot about kind of coming to terms with that, of what do you think a good death is, because you have to be certain not to put that on other people. And that's what I picture, and I've seen in working in hospice, just these beautiful home deaths where we allow death and people have resolution of things in transformation and transcendence, and allow people to take care of them at the end of their lives, and then their lives end in this kind of structured way. And then I see other people, why that happens so infrequently is people trade that good death for attempts at living longer, or as someone once put, everyone wants a good death, but not now. And the consequence is that is dying looks like medical illness, and people come into the hospital and we're hoping it's not dying. And then at the point we realize it's dying, it's in the last hours to days, and people die in the hospital, and we do our best there. And so I have a different idea of what a good death is in a hospital. And it includes hoping for the best and working towards recovery, but also preparing that what if this is the end, or what if time is short, or do people have a far way to travel? So that's what a good death is in the hospital. And then there's a good death in the intensive care unit, where somebody is put on a ventilator at the end of their lives, hoping that it's not the end of their life, and then it turns out that they are at the end of their lives, and they will continue to die even on the ventilator. And now there's no more purpose to the ventilator, that we remove it and we allow that process that started before they come into the hospital, we allow that. We remove what we did, and we allow their lives to end from their lung disease. And that's a good death in the ICU. I had a patient when I was not in Vermont, who I wasn't as involved with as one of the hospice attendings, who had advanced prostate cancer, and he was a lawyer, and he lived alone, and he was all about maintaining his independence, and hospice helped him do that. And he wanted to know that when he was done, that he could go fast, and he didn't want to linger. And in his mind, what a good death was not being in a protracted state of suffering for long. And he wanted confidence that when he was ready, that they would help him die. And what they described to him was that they would not abandon him in any ways that he was suffering, that they would allow him to be comfortable, and that they could allow and help a peaceful death. But he probably wasn't going to be able to die at home, and he wanted to die at home, and he didn't have caregivers. And as he got closer to the end, he had talked with another member of the hospice team, but he had understood that the hospice had contracted with him that they would help him end his life when he was ready. And that isn't what they were really saying. What they were saying was, we will not abandon you. We promise you whatever comes up, that we are very skilled, that we will help you die peacefully and comfortably when it's time. And then he sort of described that he was ready now. And the hospice team didn't feel comfortable to, again, this wasn't Vermont, but they didn't feel, they wanted to clarify that, well, we can't hasten your death. We can't give you medicines with the intent of dying. And he says, well, I have a lot of pain medicines, then I'm just going to take them. And they recommended that he not do that. And he says, I am done. And this is my body. And I have, I've resolved my things. And he wasn't depressed. And this is not pathological depression. This is not pathological suicide. And he was done. And he was looking at his final days to weeks in a nursing home, or just having his life end. And so they, because he had an intent for suicide and a plan, the doctor's duty was to call the authorities, and he was taken from his home and brought in for an emergent psychiatric evaluation against his will. And he said that he says, I was just frustrated, and I have no intent of ending my life. I know I'm dying. I have things I want to do. And however he said, whatever he did, that he needed to say to make it clear that he wasn't intending to end his life. And then he went home and he ended his life. And that was his good death. And I don't think that's what I would want, but I do think there are people that that's how they want to do it. And I don't think it is suicide. And I don't think it's what hospice and palliative care wants to be doing. I don't think it's anything that we would ever, if it were legal, describe of all of your options, or when someone's really suffering to bring it up, because I don't even bring up palliative sedation, because I do think there's a natural way that we can help, like there's a process that happens and we can help that, and that even when it's hard, there's some things that resolve through that. But I haven't talked much about this at work or with anybody, but my decision is I don't oppose the legislation, And I don't know what I would do if it was passed, but I do believe that there's a reason why people do this that is not achieved through palliative sedation or stopping eating and drinking. And it's a very few number of people. It would amount to be, if we were typical like other states, it would be 7 people a year. But I just met someone in clinic last week. I don't know if this was satisfying to him, but I was asked to see somebody emergently who had end-stage heart disease on oxygen and was starting to get debilitated. And he told his doctor that he was preparing that at some point he was going to let his life end or end his life, and had a couple of ways he would do that. And he had talked with his primary care doctor, and his primary care doctor had told him, look, you don't realize it, but there's a lot we're doing that is extending your life right now, like oxygen. That when that doesn't achieve your goals, like oxygen right now is helping you be independent, helping you live the life you want. And if you're at a point where it's only extending a dying process, we can stop the oxygen, and we can administer medicines for shortness of breath and allow sedation, which is probably what you would need to be comfortable without oxygen anyway. And then we allow your life to end from lung disease, and we stop, or from heart disease, and we stop preventing your death. And then death will happen. And he was dissatisfied with that. It was too vague. It was, how much time would that be? Or if I were to stop eating and drinking, and he had read about that, and he said that just doesn't feel dignified. And I'm still lingering at the end of my life, and why can't we do what we do for our dogs? And I'm sure you hear. But he just felt like that was an unsatisfactory means. And I told him I supported that plan. I thought that I reinforced that you don't realize just being ready and stopping things, that death happens, that we've extended life in so many ways, that it doesn't take much to allow death. And I described what dying looks like, that it'll just be triggered and dying will happen just like if you think of it, he had shared someone in his family who died just like that. It'll look just like that. But I know his primary care doctor is trying to get the guns out of his house, and that's because I described to him what I think the best we can do for you. But that sort of period of time, that's not how he wants it to go. And he's using all these medical therapies and technologies to extend his life now. And there's a lot of off-ramps that we prevent death in so many ways that you can reach a place where you plateau and there's no off-ramp and you are done and you're suffering. And that's a consequence of medical therapies. That's what we've created. And so this is the work we do, is alleviating whatever it takes for people to be comfortable when they're at the end of their lives. But most of what we do in palliative care and hospice care is about living well and preserving life and preserving quality of life. And a lot of people that say they want this, feel like when they're ready and they're at the end of their lives to not, to stop a prolonged dying. A lot of people don't use this method. It's more just that they want to know, that they have confidence in that. So while you're preventing my death now and keeping me on the road, and I'll put up with this, but there's a point where this is going to be too much and I'm going to be done. And that's the kind of the people that I've worked with. But do you have questions for me?
Other than the man in the corner?